malignant one, of course, will be osteosarcoma. So let's start. Right. So in terms of the benign osteogenic tumors, which means that are derived from bone, you have osteoid osteoma versus osteoblastoma. Incidence, you wouldn't get asked that in exams. I just put up the slide so you all could read it in your own free time. But the size is what matters. So osteoid osteoma is usually less than 2 centimeters, whereas osteoblastoma is usually greater than 2 centimeters. The location is very important. In terms of osteoid osteoma, it tends to occur in the long bone diaphysis. So you'd have somebody presenting with pain along the midshaft of the femur, pain along the midshaft of the tibia, pain along the midshaft of the humerus, whereas in osteoblastoma, they would give you the classical example where the patient presents with back pain and you've seen a lesion in the posterior elements of the spine. So patient would present with scoliosis, so they present with back pain. Now, just from that alone, if I ask any of you all guys, so we have a 15-year-old patient who presented with mild scoliosis to the right, and he has a history of pain in the spine. X-rays pick up a sclerotic lesion on the posterior element of the spine. He tried anti-inflammatory meds, and he did not really get any relief. What would your diagnosis be, guys? Anyone?
The osteoblastoma.
Exactly, osteoblastoma. So this is a sort of didactic session, right? So when I ask questions, I expect you all to jump up and answer, because in exams, that is how it's going to be. It's you versus me or you versus the examiner alone. Right. In terms of the osteoid osteoma, is usually self-limited. So whether you treat it or you don't treat it, eventually as the patient reaches skeletal maturity, which is usually just 17, 18 years, the condition itself resolves. So that's the next classic part in the history, usually in pre-adolescent patients. Whereas in osteoblastoma, it's progressive. So after adolescent, the symptoms progress. Now, key example here, or key history is that in osteoid osteoma is usually relieved by NSAIDs because the tumor itself produces prostaglandins, and the prostaglandins generate pain. So for instance, you'll have a young female presenting with night pain in the mid-thigh. X-ray shows osteosclerotic versus surrounded by a rim osteolytic lesion. Is relieved by NSAIDs. The answer will be osteoid osteoma. Why? Because the tumor produces prostaglandins. Therefore, anti-inflammatory medication, which are the NSAIDs, which will inhibit prostaglandin production, will relieve the pain. Whereas in osteoblastoma, it does not. And 50% of these patients with the lesion in the back of the spine would have neurological symptoms. In terms of osteoid osteoma, non-surgical management is indicated as first line. Why? Because of two reasons. One is self-limiting, and two is often relieved by NSAIDs. To the self-limiting one, they usually grow out at once you reach skeletal maturity. If NSAIDs don't work, then you go in, you do your biopsy. You could remove it by nucleating it, or you could use radiofrequency ablation, find the lesion and burn it. Whereas in the osteoblastoma, surgery is always indicated as they do not respond to non-surgical treatment. So right away, guys, just to recap, osteoid osteoma versus osteoblastoma, it's imperative that when you're revising, you compare both. Don't study each in isolation. Everyone understands this so far?
Makes sense, though.
Yes.
Okay, great. Next one. So you would see in terms of the osteoid osteoma, you would see the lesion on it. So this is an X-ray. You all see my mouse?
Yes, we see it.
Right. Right. So you'd see the plain X-ray here, the osteoid osteoma. Patient have thigh pain. You would see a central nodule of woven bone, so it'll be osteolytic. And then as they have osteoblastic rimming to try to enclose the lesion. So around it will be a sclerotic margin, right? And then you'll have thickened bone. This is the CT scan showing it here as well. Whereas in the osteoblastoma, you would see that it's in the posterior elements of the spine. So both of them tend to kind of look the same, but the location is where the giveaway is. In terms of the osteoid osteoma, in addition to X-ray or CT scan, one of the key things in your MCQ is you could do a bone scan, and you'll see an intense hot area of focal uptake at the nidus, as seen here, right? Now, the reason why I put up this slide is simply because we did not say that osteoid osteoma cannot occur in the posterior element of the spine. Neither did we say osteoblastoma cannot occur in the long bones. We just say it's more prominent. So if you faced in exams and I show you a lesion here in the spine, but there's the bone scan lights up, you have an intense focal area uptake at the nidus, and you see a double density sign because one area is intense, and in the reactive zone, which is rimming the lesion, it's a low uptake. That is key finding of an osteoid osteoma. So sometimes we could try to trick you in questions, but once they hear bone scan, and they say the bone scan show intense uptake, and you see that double density sign, that's osteoid osteoma. Are you me? Please move that shoes from there. Do not put it on his step or close to him. Sorry about that. Right. And as we mentioned before, pain attributed to increased local concentration of prostaglandin E2. Therefore, the anti-inflammatory meds, which display COX-1 and COX-2, would be able to sort out the osteoid osteoma. Relief by NSAIDs. Right? Treatment, either surgical resection, I could use radiofrequency ablation. Osteoblastoma, we already spoke about that already. Right. Let's move on to the cartilaginous tumors, benign cartilaginous tumors. Just now we spoke about the benign osteogenic tumors. Now we're going to speak about the benign cartilaginous tumors. The first one is osteochondroma. As the name implies, osteo is bone, chondroma is cartilage, which means there's a bony portion and a cartilaginous portion. Therefore, it will occur close to the metaphysis. It will occur close to the metaphysis where you still have a cartilaginous part because of the growth plate, and then you have your bony part. And quite often we'll bring a classic example of somebody presenting with knee pain. At least 50 to 70% of the cases occur around the knee, whether it's distal femur by the metaphysis or proximal tibia by the metaphysis. It can also occur in the humerus as well. Anywhere you have metaphysis, it can occur. It could occur in the ankle as well, just proximal to the ankle joint. And histologically, you'll see something like this, like a mushroom, where the stalk is the bony part and the cup is the cartilaginous cup. Now, on an X-ray, you would not be able to appreciate the cartilaginous cup because cartilage do not show up on an X-ray. All you will see is a pedunculated lesion at the metaphysis, and the patient will complain of mechanical symptoms because of surrounding compression of structures, whether it's muscle, fascia, the neurovascular structures, especially if it's in the medial aspect of the thigh. Patient will complain of symptoms. Again, as I said, it is benign. Some patients may present with multiple osteochondromas. As seen in this diagram, you have it on the metaphysis of the tibia, you have it on the metaphysis of the femur, sometimes they could have it in the humerus, and they have multiple. In that case, the condition is called multiple hereditary exostosis. It's autosomal dominant, and it occurs in the EXT1, 2, and 3 genes. That's as much as you all need to know. Multiple osteochondromas, still benign. They're still benign. and they're autosomal dominant in the AXT1, 2, and 3 genes. There is a small risk of transformation of osteochondroma to chondrosarcoma, which is a malignant tumor. Now, in that case, the patient may present with progressive growth of the lesion, they may present with progressive pain of the lesion, and sometimes there are syndromes that could occur with, like the multiple hereditary exostosis. Those patients may have a higher predisposition towards malignant transformation than a patient with just an isolated osteochondroma. Nonetheless, if you suspect that these patients have malignant transformation as evidenced by increase in pain or increase in size, then you need to do an MRI scan. The MRI scan will show you the cartilaginous cup. It will show you other characteristics of the lesion that the X-ray may not show you. You all don't need to know these characteristics. All you all need to know is the steps involved in recognition of a malignant transformation. Boils down to history, so you'll have to see constitutional symptoms, weight loss, any pathological fractures, night sweats, etc., etc. How many lesions they have, you X-ray the entire body, you MRI the lesion of interest in the thigh, followed by biopsy. So you always do your triple assessment, as you all know: history and examination, investigations, and your biopsy. As just like in general surgery. Once you have that protocol in your head, even if you don't know the answer, the examiner will see that you have a logical sequence of steps in which you investigate any potential malignant lesions and you at least pass. Now, one of the things I didn't mention, so we spoke about cartilaginous tumors, which is the osteochondroma, and these cartilaginous tumors are benign, but they occur outside the bone, as you could see here, so you could feel them, and they are cartilaginous in origin. They have the ones that occur inside the bone, and let's go to those before I jump. Right. Those that occur inside the bone, and these are called enchondroma. So just like we classify osteoid osteoma versus osteoblastoma, now we're classifying osteochondroma versus enchondroma. They're both cartilaginous in origin. They're both benign, except the osteochondroma occurs outside, like a mushroom, whereas the enchondroma occurs inside the bone. And you would see in this kid here tends to occur in kids, right? And they would have swollen fingers. So it's usually the phalanges and the metacarpals of the hand, right? And sometimes you could see a popcorn type stippling on the x-ray. So you see small little white calcification areas there within the phalanges or the metaphysis and surrounding cysts. And 60% of them occur in the hand, right? So hands and feet. Could occur anywhere but hands and feet. So at your level, we're not going to bring weird stuff. If we bring enchondroma, you would see swelling of the phalanges or the metacarpals, and we'll bring it on the hand. And your answer would be enchondroma. The question would be, what is enchondroma? It says a benign chondrogenic tumor composed of hyaline cartilage located within the medullary cavity. This last part, for those who are going for distinctions, Olliers disease is usually when you have multiple enchondromatosis, as in this case with this child. Usually when you encounter an enchondroma, you all hear me?
Yes, sir.
Yes, yeah.
Usually when you encounter an enchondroma, it would be a benign lesion within one phalanx. When you have multiple enchondromas, you think about Olliers disease. Why this is important? Olliers disease, as opposed to enchondroma, have a 30% risk of malignant transformation. 30% risk of malignant transformation. And for those of you all who are going for beyond distinction, there's a condition associated with multiple enchondromatosis, and multiple vascular lesions, whether it's hematomas or malformations, any vascular lesion, and these lesions could occur in the GI system, they could occur in the peripheral system, they could occur in the brain, they could occur anywhere you have a blood vessel. So the combination of multiple enchondromatosis and vascular lesions, there's a condition called Maffucci syndrome, right? Maffucci, is either two F's or one F. I think it's one F and two C's. Maffucci syndrome, and that has 100% chance of malignant transformation. 100% chance. Why is this important? You do not want to miss a child with multiple enchondromas, and you just say, okay, this is benign, go home, and then they present a couple of months after wasting. So this is so important to recognize that some of these syndromes can be life-threatening in these cases. So everyone understands the benign chondrogenic lesions now?
Yes, sir.
Good. Let's go to the cysts. Right. When we're speaking about cysts, we usually speak about two types of cysts, either the unicameral or simple bone cysts, both of them. Just our next. The American Society of Orthopedic Surgeons have changed the name from simple bone cysts to unicameral bone cysts. And so, but you all could still use simple bone cysts. So it's unicameral bone cysts versus aneurysmal bone cysts. Now, what are the differences? This is where this table comes in. Very important. Common location for the simple or unicameral bone cyst versus the aneurysmal bone cyst, usually the proximal humerus. So the patient could present with pain in the proximal humerus versus the aneurysmal bone cyst. It could present in the long bones as well as it could present in the spine. But at your level, again, we'll give a proximal humerus if we want you to identify the simple bone cyst. Why? Because that's the classic location. The simple bone cyst, it looks something like this. You may have cortical thinning. It may look multiloculated, just like the aneurysmal bone cyst. So don't think that the simple bone cyst just has one loculation. It may be multiloculated. The difference is the simple bone cyst fills the medullary cavity. It does not expand the bone, whereas the aneurysmal bone cyst is expansile. So as you could see here, the cortex in the aneurysmal bone cyst is very thin, and sometimes it can be obliterated. Whereas in the simple bone cyst, the cortex is still intact. It may be thin, but it's still intact. And the aneurysmal bone cyst also occurs on the metaphyseal side of the physis. Right, so this is your physis here, which is your growth plate, and the aneurysmal bone side is on the metaphyseal side of the physis. Sometimes the simple bone cyst could cross over. And we just put this drawing of a giant cell tumor because sometimes the giant cell tumor, which is very common at your level, we could bring that question, looks just like a lytic lesion. The difference is giant cell tumor occurs after fusion of the physis, which means you would not see a physis in a patient who has a giant cell tumor. Whereas in the simple bone cyst versus the aneurysmal bone cyst, you will still appreciate the growth plate. So any x-ray we give you guys that you see in a growth plate, don't think giant cell tumor. Think simple versus aneurysmal. Aneurysmal is expansile, it could obliterate it, and is always on the metaphyseal side of the physis. It's never on the epiphyseal side. Simple bone cyst, cortex intact. It may be multiloculated. Giant cell tumor, no growth plate present, and most of them in giant cell tumors occur around the knee. A good 70% of them occurs around the knee. You can't get giant cell tumor in the distal radius. You could get a giant cell tumor of the tendon sheath itself. You could get it pretty much anywhere, but it's after the closure of the physis And in the giant cell tumor, it extends just below the articular surface, whereas the aneurysmal bone cyst does not. Right. The contents of the simple bone cyst is fluid, is cystic, whereas the contents of the aneurysmal bone cyst is hemorrhagic. So if you were to biopsy a simple bone cyst, you would see a cystic, clear serous fluid coming out, whereas in the aneurysmal bone cyst, it will be hemorrhagic. You will see blood. Prognosis, the simple bone cyst usually resolves spontaneously between adolescence and adulthood, just like the osteoid osteoma, where there's a growth plate. It's be active at that point in time. Usually once you reach skeletal maturity, it resolves itself. So once you have a report from a radiologist stating this is a simple bone cyst, the x-rays are indicative of a simple bone cyst. There's no need to biopsy. Right? The aneurysmal bone cyst may need some treatment if it's expansile and if it's damage in the cortex, because they could present with a pathological fracture. The conservative management, if you do have to manage a simple bone cyst, you could inject steroids within the simple bone cyst. How you do that? You carry the patient in theater, use a C-arm to locate the cyst, you make a small cut in the skin under general anesthesia, you drill a hole in the cyst and you inject steroids. So you reduce the inflammation. In an aneurysmal bone cyst, again, you use sclerotherapy and you could use alcohol. If the simple bone cyst is causing symptoms, are you me? If the simple bone cyst is causing symptoms and failure of conservative treatment, then you will need to go in there surgically and curette the simple bone cyst. And you'll have to graft the defect. You'll have to graft the defect and put bone graft inside there or cement. One of the things that we tend to use is bone cement in the lesion. Sometimes if you put cancellous graft, it will become resorbed, especially if the simple bone cyst is in the active phase of growth. So it's very important when the patient has an active simple bone cyst, as evidenced by pain and or pathological fracture. At that point in time, you tend to not do much. You leave it, let it become quiescent. When it becomes quiescent, then you will go in afterwards. When you go in afterwards, you could bone graft and fix it and so forth if you need to. The reason why you don't do much surgically during the active phase is the bone graft, if you go in there, it will resorb the bone graft. So everything that you put in there will become wasted. So you have to treat them conservatively, even if they're fractured. So you have a young child present with a unicameral bone lesion in the proximal humerus. It fractures. You tend to, okay, I want to fix. No, you don't fix. Keep them in a collar and cuff. Keep them in a U slab. Let it heal. And afterwards, when it heals and becomes dormant, then you go in there and you could bone graft these patients and you could fix them. Right? In terms of the aneurysmal bone cyst, you do aggressive curettage and you could use bone grafting. Again, the choice of graft is important. We try not to use too much of cancellous graft because it gets resorbed. It's beyond your requirements, I should say, in terms of the type of bone graft we use. But what you need to know is conservative versus surgical and when we would do any one of those. Right? Now, in this case, in the back of your head, okay, look, there's a large cystic lesion in the ankle. It obliterates the cortex and your eyes. This is aneurysmal bone cyst. Why isn't this an aneurysmal bone cyst? Anyone?
Because we're not seeing the phases.
Perfect. Because there aren't any growth plates. So that's the giveaway there. So The next thing in the back of your head is this benign, is this malignant? And the examiner would not fault you if you think it's malignant. You could say, Doc, I would like to do my triple assessment, history, and examination, followed by investigations, followed by biopsy. And then he will say, okay, it's a benign lesion. Forget about biopsy. What do you think it is? Say, well, there aren't any growth plates. It's lytic. I am thinking a giant cell tumor. They'll be like, why not a simple bone cyst? Why not an aneurysmal bone cyst? Because there aren't any physes. Excellent answer. Now, while we're on the topic of giant cell tumor, one of the things we love to ask in MCQ is tell me histologically, when you biopsy it, what type of cells you would see. And a lot of students, for some strange reason, would say giant cells. They'll see polymorphonuclear giant cells or multinucleated giant cells. No. The neoplastic cell in a giant cell tumor is a mononuclear stromal cell. So if you get asked that in MCQ, histologically you're looking for a mononuclear stromal cell. Now, giant cell tumor, when we classify bone tumors, there's the Enneking classification of bone tumors, Enneking. Enneking essentially classified tumors into three types. Bone tumors we're speaking about, benign, malignant, and there is a category in the middle that are benign, but they can be aggressive. Which tumor falls in that intermediate category? Giant cell tumor. And giant cell tumor could present in one of three ways. It could present latent, it could present active, and it could present aggressive. In terms of latent versus active versus aggressive, latent would be a lesion in which the cortex is intact. So obviously this lesion here isn't latent. Active would be a lesion that is expanding over time, and aggressive would be a lesion like this, where the entire cortex is obliterated. So this would be an aggressive giant cell tumor. Even though it's not malignant, and even though it's benign, in the aggressive forms and some of the active forms, there is a 3% chance that a giant cell tumor could spread to the lungs. 3%. The ones that tend to spread to the lungs, surprisingly, are the ones that occur in the distal radius. So it's a young patient in their mid-30s present with wrist pain. You x-ray the wrist, you see the distal radius obliterated, pretty much like this distal tibia you're seeing here. And then they'll ask you, okay, what you think it is? So this is a lytic lesion. I'm not seeing growth plates. So it could be a benign lesion, it could be a malignant lesion. If they say it's benign, say, well, giant cell tumor is top on my list. Say, what are the investigations you need? Say, well, there's a 3 to 5% chance that it could spread to the lungs. So I'd want a CT scan of the lungs, in addition to a CT scan of the bone itself, to give you a better idea of the anatomy, because the patient would need reconstruction and excision of the lesion. In terms of the treatment, you can see here, this is an aggressive lesion, right, with regards to the giant cell tumor. It's a poor diagram, I do apologize, but the proximal tibia is almost obliterated, right? So in terms of treatment, you could try bisphosphonates, or you could try denosumab. 2 seconds, guys, just give me 2 seconds. Cristiano? So, anyone know how well, I spelled it wrong. Anyone knows how bisphosphonates work?
They inhibit osteoclastic activity.
Okay, good. It inhibits osteoclastic activity. Very good. And denosumab is a monoclonal antibody against the rank ligand. FYI, the rank is just something that stimulates osteoclast. So indirectly, it inhibits osteoclast, denosumab. So it helps prevent bone resorption, just like the bisphosphonates. It doesn't target the giant cells itself, it just helps prevent bone resorption. So these are two conservative ways to treat giant cell tumor. And we tend to use the conservative management in someone who has a latent form of the giant cell tumor or active form of the giant cell tumor. If they have aggressive form of the giant cell tumor, then you would probably want to resect the tumor in that case. Right? So in terms of resecting the tumor, you could actually resect the entire bone and replace it with a allograft, or you could resect the entire bone and replace it with a prosthesis, or you could fill, if there's any active form and there's still cortex available, you could fill the defect seen here, you could fill the defect with cement, bone cement, or cortical allograft, or so forth. You try not to use cancellous allograft in any of these tumors because it tends to become resorbed. Good. So I think we should have a fair understanding of the benign lesions when faced with it in exams. The malignant lesions, osteosarcoma, again 75% of them occurs around the knee. So we would bring an exam question where you would see some patient present with an expanded lesion in the proximal aspect of the thigh, and the patients would have constitutional symptoms, weight loss, spread to the lungs, etc., etc. When you look at the X-ray, it's the Codman's triangle, which is this triangle right here, which is just periosteal elevation, and you see characteristic blastic activity. Blastic is the white and destruction of the bone. So you see these lesions here. There's a lot of osteoblastic sclerotic lesions that you would see. There is a bimodal distribution. Majority of them occur in the second decade of life for osteosarcoma, but there's a second peak in elderly patients who may have Paget's disease. You all may not see Paget's disease in our population. It's more linked in the Caucasian population and the European population. But just to know, in case you get it in MCQ, there is a bimodal distribution. Mainly in kids, but in the elderly patients, if they have Paget's disease, also look out for transformation of Paget's disease into osteosarcoma. Patients who carry the retinoblastoma suppressor gene are predisposed to osteosarcoma. In terms of investigating these patients, they need to do an MRI of the site of the lesion, which is the knee in this case, because it could extend into the soft tissues, and you need to do a CT scan of the lung. The treatment is a combination of chemotherapy versus surgery itself. The survivorship has improved to about 75% because what we have started to do is neoadjuvant chemotherapy. We would give them chemotherapy prior to the surgery to downstage and downsize the tumor so that it will be a bit better to resect, and we usually do that for about 12 weeks. Then we perform the surgery, and it must be a multidisciplinary team. You must have your radiologist as part of the management team. You must have your orthopedic surgeon as part of the management team, preferably a tumor surgeon orthopedic. If the lesion on the MRI surrounds the blood vessels, because it's around the knee, you have to have your vascular surgeon around there. The oncologist must be on board because they will take the biopsy and they will tell you what type of osteosarcoma, because there are different types. So the most common being osteogenic osteosarcoma. And following the surgery, once the wound heals, just start them back on post-operative chemotherapy, right? And the aim is whether you want to do limb salvage or limb amputation. Both have downsides and both have benefits. The downside of limb salvage is pardon? The downside of limb salvage is that the tumor can recur. Because in limb salvage, you leave borders. You go a couple centimeters, proximal and distal to the tumor, but there are still micrometastases that could manifest even after postoperative chemotherapy. So that's the downside. The beauty about limb salvage is that the patient preserves the limb. So in terms of functionality, especially as a young patient, the energy expenditure is much less. Versus limb amputation, you're amputating the limb and they have to go in a prosthesis. If you're in a center where you don't have access to limb salvage and you don't have all these fancy things, then it's best you opt to do an amputation, because the younger you amputate, it's the more acceptable it is for both the parents and especially the child, because they grow up most of their life knowing that, okay, they have a prosthesis. And this is very important for you guys to know. And Ewing sarcoma. So those are the two malignant tumors that we need to talk about. We just spoke about osteosarcoma, right? And osteosarcoma, as you can see, is around the knee. So it's more metaphysis. Right? Whereas Ewing sarcoma is more diaphysis. 50% are found in the diaphysis, which is around the midshaft. And you can see it here, a little periosteal elevation. You can see a little lytic lesions in the shaft of the tibia here. The genetics involved is the T1122 translocation, which is found in all cases and leads to the formation of the EWSFLI1 protein. These patients can present with symptoms suggestive of osteomyelitis. So, if we have to bring a question with Ewing sarcoma, we may bring it in a setting where the differential could be osteomyelitis or Ewing sarcoma, because it could mimic an infection. How you could tell the difference? Usually in osteomyelitis, the patient would have a risk factor. In our population, and I assume there are some guys from Jamaica sitting in here, sickle cell disease is high up on the list. So if I give you in your history, this is a 12-year-old boy with a history of sickle cell disease, presented with a painful vaso-occlusive crisis, and 2 weeks after, he's found to have pain in his bones in the diaphysis of the forearm. X-ray shows a lytic lesion immediately in the back of the head. This is osteomyelitis, acute osteomyelitis. Whereas if we have a patient presents with weight loss and he have an intermittent history of night sweats and fever, he doesn't have a history of sickle cell disease, presents with a cough or spread, so suggesting spread to the lungs, Ewing sarcoma, right? Histology, small round blue cells. Remember we spoke about histology for the giant cell tumor where we spoke about the monostromal cells. That is the key thing in our MCQ for giant cell tumor. Same thing, the key cell for Ewing sarcoma, small round blue cells equals Ewing sarcoma. Don't even waste time reading the rest of the MCQ. That is Ewing sarcoma, mainly diaphysis of long bones. Now, one of the things with Ewing sarcoma is that they can have skip lesions within the same bone. In osteosarcoma, it may occur in the metaphysis and spread around the soft tissues. Whereas in Ewing sarcoma, you may have a lesion here. And then here is normal, and then in the same bone distally, you'll have a lesion. We call it skip lesions. So therefore, it's imperative when you're investigating someone with Ewing sarcoma, you must MRI the entire bone at hand. Because in the early phases of Ewing sarcoma, the X-ray may not show the skip lesion because it tends to start in the medullary cavity of the bone. And the MRI would show that, whereas the X-ray would not. Right? In terms of the Ewing sarcoma seen here, you have some periosteal reaction, and it may give this kind of onion skin or sunburst appearance, as you can see. See a periosteal kind of oval, curved bone growing aside, away from the diaphysis of the bone. It gives this kind of onion skin appearance. Metastases, as I said, it could skip and it could spread in the bone marrow. So all Ewing sarcoma equal a bone marrow biopsy. All Ewing sarcoma, because it could spread in the bone marrow. Remember, osteosarcoma spreads in the lungs. Ewing sarcoma could spread in the bone marrow. Treatment, chemotherapy, and limb salvage or amputation, whichever your center could provide. You all don't need to know the chemotherapy, just need to know investigations, MRI. Why? Spread in the bone marrow. Investigations, bone marrow biopsy. Why? It could spread in the bone marrow. Treatment, chemotherapy, followed by either limb salvage or limb resection. Now, multiple myeloma, classic, you would get a patient in their 60s, even who's over 40 years old. We'll tend to give you a patient in their 60s or 50s who present with an osteolytic lesion in their bone, any part of the bone. It could be femur, tibia, doesn't matter. Patient would present with pain. So let me ask you all guys a question. Let's say we have a 55-year-old patient who present to you with bone pain in the distal femur. 55-year-old patient. X-ray shows a lytic lesion. How are we going to investigate this? Or what are your differentials? Let me ask, what are the differential diagnoses? Anyone? Now is the time to make mistakes, guys.
One would be giant cell tumor.
Pardon?
One would be giant cell tumor.
Okay, anyone else? A 55-year-old male presents with a lesion in the distal femur, and he has weight loss over the past 6 months. 55-year-old male. Let's make it easier. 60-year-old male presents with progressive pain in the distal femur. X-ray shows osteolytic and osteoblastic lesions, mainly osteoblastic, and he has weight loss.
Monoclonal plasma cells.
Okay, monoclonal plasma cell. Anyone else?
Osteosarcoma.
Osteosarcoma. Anyone else?
It could also be metastasis to the bone.
Finally. Finally. Exactly. So tumors in younger patients are usually primary bone tumors, whereas tumors in older patients are all mainly metastases. Right? Mainly metastases. So you have to investigate a primary source once you see a tumor in an older patient. So in a male prostate, so the tumors that tend to spread to bones and the spine are usually the tumors in the midline. So starting from the top, thyroid, as we go lower, lungs, in women, breasts, both people, renal and suprarenal, organs in pairs as we go down to the abdomen, the colon. As we go further down, ovaries in women, prostate in men. Yeah, some of those will tend to have a more sclerotic pattern. So, for instance, breast and prostate tends to have more sclerotic metastases, whereas things like the thyroid tends to have a more lytic type lesion. The renal cell cancer tends to have a more lytic lesion, and that one tends to spread in the musculoskeletal soft tissues as well. Yeah, a multiple myeloma is a primary bone tumor, but you need to rule out secondary mets before you could think about multiple myeloma. Right? Which one of the thyroid tumors tend to spread to the bone? Anyone?
Is it follicular?
Yes, follicular thyroid tumor. So there's papillary, follicular, and the lymphoma and all these sorts of stuff. The papillary spreads to lymph nodes. Follicular is hematogenous spread, and that tends to spread to the bone. It tends to have a lytic lesion, the follicular thyroid cancer. Right? So now that we understand, when you have an adult, do not think primary bone tumors, think mets, and then you can think primary bone tumors. Having said that, multiple myeloma is a primary bone tumor, usually over the age of 40, but more common in the 50s and 60s. and it tends to have a lytic lesion. There is a criteria to diagnose multiple myeloma, which you all could go and read on your own. But you must do a bone marrow biopsy to see, or a tissue biopsy to see tissue plasmacytoma or bone marrow plasmacytosis of more than 30%. Again, we speak about Benz-Jones protein. We speak about lytic lesions. So you must do some kind of skeletal survey where you x-ray the skull, you x-ray all the bones in the body to look for lytic lesions. But there are major criteria and there are minor criteria. So you must have a combination of the major and minor, several minor criteria to diagnose multiple myeloma. And the management, and one of the key things in the multiple myeloma and the MCQ is that the bone scans are cold in 30% of these patients. So they don't have much osteoclastic activity, going on there. The bone scans are cold, not much activity going on there. So therefore, that is the key in an MCQ. You say this patient presents with a lytic lesion, he's 60 years old, he has multiple lytic lesions, bone scars were done that showed cold uptake. What do you think it is? Answer, multiple myeloma. Once the bone scan cold, multiple myeloma. Right. So that's the end for tumor. You all still have energy in you all to do some trauma?
Yes.
Yeah.
Okay, let's start the trauma. The trauma is the bigger one. I know the bone tumor is the more difficult one. So let's start. Right, you all seeing?
Yeah.
Okay, good. So in the Viva, you usually have, well, you will have a table, and the table will have a combination of instruments. You'll have a combination of wires and all these sorts of stuff, prosthesis implants. Sometimes might have cast padding, and we could just pick it up and ask you what this is. And most students, unfortunately, just prepare for trauma. And if you get asked these things, these are easy marks, and then because you haven't read it, you would fail. So this is a classic example here of antibiotic beads. It looks like a necklace, and what it is bone cement. The bone cement that we used to use would be calcium phosphate, so it gets hard, it's insoluble, so it doesn't dissolve, and we would put it in some those circlage wires that those thoracic surgeons would use to close up the chest after they do a surgery, and we would just mix these with antibiotics itself, the cement form of the antibiotics. So it mix the bone cement, which is calcium phosphate, with your antibiotic, whether it's Zinacef powder, Marinum powder, vancomycin powder, doesn't matter. Add saline to it, form a dough, roll them into small circles and feed them through the wire. So if I show you all this, the next question would be, where would this be indicated? And your answer would be, well, this would be indicated in a patient who presents with osteomyelitis. And I'd be like, well, why would you use antibiotic beads in someone with osteomyelitis? And your answer would be, well, in patients with chronic osteomyelitis, they have two things. They have a sequestrum and they have an involucrum. A sequestrum is the dead bone. That is the destruction of the bone by the bacteria. So it's dead necrotic bone, which is a nidus for infection. The involucrum is the reactive bone that forms a shell around the dead bone. It's the body response to the defect in that particular bone, and it tries to grow new bone around it. So it encases the sequestrum, which makes it worse because then the pus and the dead bone have nowhere to go outside, so it keeps expanding within the bone marrow. Therefore, in treating osteomyelitis, it's important to understand that there's acute, there's subacute, and there's chronic. In acute osteomyelitis, there's no sequestrum, there's no involucrum. The infection now starts in the absence of an abscess, in the absence of any localized collection. Once the MRI shows that it's just simply acute osteomyelitis, you can't treat them with intravenous antibiotics. If, however, this patient has chronic osteomyelitis, as indicated on your X-ray, and then you'll follow up that with a CT scan and an MRI of the area, and it shows a sequestrum and an involucrum, you now need to do surgical debridement plus antibiotics. So then the surgeon will ask, well, why if you debriding the dead bone and whatnot, why, and you given intravenous antibiotics, why would you put antibiotic beads? And your answer would be, well, doc, in the setting of chronic osteomyelitis, there's repetitive inflammation and healing and inflammation and healing, and the environment in that bone, after months and months of infection, is usually encased by a lot of scar tissue. And when there's a lot of scar tissue and chronic inflammation, the blood supply is dwindled in that area. And where the blood supply is dwindled, even if you give IV antibiotics, not much of the intravenous antibiotics would reach the tissue level at that area. So the concentration would be less, and if there's any remaining bacteria after the debridement, unfortunately, the IV antibiotics may not reach it. So therefore, we need something that could leach a local concentration of antibiotics over time. And this is where antibiotic beads come in. And then the next question will be, well, why not just pack the antibiotic powder itself? And your answer will be, well, if you do pack the antibiotic powder within 24 hours, the half-life of most of these antibiotics goes within less than 24 hours. However, if you combine it with calcium phosphate cement, it is leached over several weeks. So you have local concentration at a slow rate being leached out every single day. Plus, they give you IV antibiotics. Yeah?
Yes, sir.
Anyone knows of any classification system for osteomyelitis? Right, there's the Cerny and Maeder classification for chronic osteomyelitis, CIERNEY and MAEDER Maeder classification, and it classifies osteomyelitis based on anatomical as well as physiological status of the patient. Right, so just give it a read how you monitor treatment, ESR and CRP. You may be asking exams, is the half-life of CRP, what's the half-life of ESR? And why you should combine both versus just one. CRP is more specific than ESR, and they are non-specific inflammatory mediators. Good. Next one.
Please repeat the classification system for osteomyelitis.
Cerny and Maeder. Cerny and Maeder. Yeah.
Yes, sir, Doc. Good evening. What antibiotic powders did you say are used with the beads?
Right. In understanding, this is a bit beyond your knowledge, but I'll mention it nonetheless. When you mix it generates an exothermic reaction. So the cement itself gets very hot. So for those of you all who ever scrubbed in a total knee replacement or a total hip replacement or a cemented bipolar, where the surgeon was mixing the cement, you realize that the cement gets very hot. So it's imperative when prescribing antibiotics that the antibiotics you prescribe are not heat labile, because the heat generated from mixing the calcium phosphate cement with the powder would kill the antibiotics. So therefore, some of the antibiotics that heat stable are Zinacep, which is a second generation cephalosporin, gentamicin, which is an aminoglycoside, I believe, vancomycin, and we could use Meronem.
Thank you, Doc.
Yeah. Now, external fixators. where would you all see this used? This is, I mean, you all would never see this bar here, right? But what you all will see is the pins and a more modern type of a bar frame that holds the bone. At your level, we tend to use external fixators in patients who have open fractures. So all open fractures equal external fixators at your level. Why do you need an external fixator? Why do you not go immediately and put a plate and screw on the bone? Why? Because the periosteum is stripped, the bone is more than likely contaminated with bacteria, it's contaminated with dirt, it's contaminated with whatever material is there at the injury site. As much as you debride and wash out at the point in time in injury, there will be bacteria there, and you put a plate and you're looking for hardware infection. The beauty about the external fixators is that you put the pins away from the open wound. So let's say the open wound is here, you put the pins a good few centimeters on either side away from it, and a further 2 pins at the extreme, and then you use a bar. So by doing that, you're stabilizing the bone without interrupting the open fracture site itself. To decrease the chance of developing infection, hardware infection. Now, when a patient presents, actually we'll cover that later on. We will ask you what are the indications for external fixator. The external fixators could be used in open fractures. Sometimes we could use external fixators in pediatric long bone fractures if we don't have access to implants. So if the child is very small, even in closed fractures in kids. Let's say you have a young kid who have a femur fracture, and you do not want to put a plate and cause this big scar on the child thigh, and is a minimally displaced fracture. You can put an external fixator. That's the next indication. Next indication for external fixator if the patient is hemodynamically unstable. So the patient is unstable, and at that point in time, fixing them, opening them up would cause too much physiological stress on them. You would place an external fixator to temporarily stabilize the bone. Once you temporarily stabilize the bone and the patient is stable, later on, you can do your definite fixation. So those are 3 indications for external fixation: open fractures, certain long bone pediatric fractures, and multiple fractures where the patient is hemodynamically unstable. I'm sure you all saw Steinman pin, so I could bring this for you, and I would ask you, when have you seen a Steinman pin being used? Anyone, when have you seen a Steinman pin being used? Chanel?
In long bone fractures?
Long bone fractures and what? And guys, don't feel bad. Now is the time to learn how to answer Viva questions. What long bone fracture, Chanel?
Closed, not open.
Close. So what you'll do this time and pin?
So it goes into the cortex of the bone.
Okay. Let's ask someone else. Adam.
Yeah. Good afternoon. You can hear me?
Yeah, I can.
Yeah. Yeah, so the Steinman pin is usually used for dislocation of the hip, fracture of the acetabulum, the shaft.
What you're gonna do this time and pin?
So usually it's inserted in from the lateral to the medial aspect of the proximal tibia, and it is used to for traction, for external traction, for traction before surgery.
So the number 1 indication for a Steinman pin, guys, is when you have a femur shaft fracture and you want to apply skeletal traction. That is your opening answer. A stymon pin is usually used when we have to delay surgery for whatever reason, and we need to apply skeletal traction. It could be for femur fractures. It could be in a patient with a dislocated hip, as you said, Adam, in which you reduce it and they have associated acetabular fracture and it keeps popping out. So you want some form of traction to keep the hip in. But when your tumor is used for a dislocated hip, I start to panic there. I think you bail yourself out in the end. And yes, you apply it from lateral to medial. And the reason why you apply it from lateral to medial is you can control the entry point, but you cannot control the exit point. So the reference point is the tibial tuberosity, right? The reference point is the tibial tuberosity. Anyone has seen a stymon pin being done? Yes, doc. Right. So it's local anesthetic. You consent the patient. You numb the area from lateral. It's 2 finger breadths. It's distal to the tibial tuberosity. And 2 finger breadths, so 2 centimeters, posterolateral to the tibial tuberosity. You create a wheal in the skin, make a small cut. You take your artery forceps, you dissect down to the bone, you infiltrate down to the bone. You make sure the patient is lying flat, and you drill at 90 degrees to the lower axis of your tibia. You drill from lateral to medial. Why? Because you could control the entry. Sometimes when you drill in and the drill hits the bone, it deflects and you can't control the exit. But we know the peroneal nerve is already lateral, the common peroneal nerve. And you drill in anterior to the peroneal nerve. So regardless of what you do, you're not going to touch that peroneal nerve. And the only structure that you could potentially damage medially would be the great saphenous vein. So it's better to damage the great saphenous vein than to damage the peroneal nerve, which could result in a foot drop. Next question. Anyone ever saw this before? So this is a dynamic hip screw. When you would see this used, this would be used for extracapsular hip fractures. So anyone who has an extracapsular hip fracture, you would see a dynamic hip screw being used. We'll talk about that later on. We may have to split this session into 2 because it's quite a lot, and I think most of you all will get tired by the time we reach the end. So we'll see how far we could go. So a dynamic hip screw, if you see it on the table, this would be used in extracapsular, specifically intertrochanteric hip fractures. Right, and as you can see, this is the thread of the screw that goes in the head, and this is the shaft of the screw that goes into the plate. So it's 2 components to a dynamic hip screw. You have the plate with the barrel, and then you have the screw that goes into the barrel itself. You wouldn't really see that. We may not bring this either. We'll bring some plates. We'll ask you what plates are these. Just say these are plates that we'd use for open reduction, internal fixation. We'll say what type of fractures. Do not say femur. Say you could see it in forearm fractures, you could see it in humeral fractures, and sometimes you could use plates in proximal tibia or distal tibia fractures. But usually the long bones in the lower limb, which are the tibia shaft and the femur shaft, we would use femur nail or tibia nail. If it's the proximal tibia or distal tibia, we could use a plate. But forearm fractures are plates and humeral fractures are plates. Nancy nails, you'll see this in the pediatric population, especially in those kids who have like forearm fractures, kids who have distal femur fractures, and the young kids, you could use Nancy nails as well. What we call elastic nails. The more recent ones are the elastic nails that we have. Right, plaster of Paris. So you probably see this all the time on the ward and you take it for granted, and we show you this pack and we ask you what is that, and you panic. Simply say this is plaster Paris, or gypsona as we know it, and is anhydrous calcium sulfate. We rehydrate it with water and we apply it over cast padding. So reduce the fracture, you apply a cast padding or your Velban as the British call it, and you wrap them with the plaster Paris or gypsona. We tend not to use it in the adult population because it cracks quite easily. In the adult population, we tend to use Scotch cast, which is fiberglass. That one gets hard. It's more difficult to work with, but it's stronger. The plaster of Paris is easier to work with, but it breaks quite easily. So unless it's a very small pediatric population, it better you struggle with the Scotch cast or fiberglass. Right? The downside of the plaster of Paris is that it's heavyweight compared to the fiberglass, and the requirement is that the cast remains dry. So the patient goes home, they get wet, the cast will get soft again and it could deform. Whereas with the Scotch cast, fiberglass, even if it gets wet, the cast maintains its shape, it maintains its strength. So it holds the bone regardless. In some patients, especially pediatric patients who have, let's say, a femur shaft fracture, and you want to put them on traction. Let's say we have a 7-month-old kid or 1-year-old kid who has a femur shaft fracture. You would not put them on skeletal traction. You'd want to put them on skin traction. If you see any kit like this, with a kind of elastoplast material, that is skin traction. Skin traction avoids drilling a child leg. The beauty about skin traction is that it could tolerate a certain weight. Skeletal traction, you could go up to 10% of the patient body weight, whereas skin traction, you have to go far less, no more than 10 pounds, because the plaster could peel off the skin. That's the problem about skin traction. Just a halo, you all won't really get that in exams. This is what you all will get in exams. Anyone, what's this that the arrow is pointing to?
Heavy arthroplasty device, so the osteomorphosis.
Very good. Why did you say Austin more? Why didn't you say bipolar?
Because it's only one. Because that's
One component.
right.
Perfect.
The component, yeah.
Yeah, just one. The head is built into the stem versus the bipolar. The stem is separate from the head. Now, anyone here? Just let me go back. Let's say these nails are in exams. You have this nail here, and then you have these nails here on either side. How do you differentiate which one is the tibia versus which one is the femur nails?
The femur is straight and the tibia is the one that's curved.
Pardon?
The femur is straight and the tibia is the one that's curved. That have the little hook to the top. That's
Good. So the tibia has a small bend to the top and then is straight, whereas the femur isn't straight as a matter of fact. The femur has a bow. The entire femur is a bow. And that bow mimics the bow of your femur. Human beings have two bows in their femur. They have an anterior bow. So if you stand up sideways and a patient is lying down supine and you shoot an x-ray at their femur on the lateral view, there'll be a very mild convex bow. That's an anterior bow. And they also have a lateral bow. So therefore the nail for a femur has to mimic the bow. So it's a gentle bow from the top of the nail straight down to the bottom of the nail. Whereas in a tibia, the entire portion is straight except the entry point, because it has to do with placement of the nail. And that's an easy way to identify. And many times we show students the nails and they can't identify. If you forget everything I said, just read it. All the nails, you just pick it up and you look at the writing and you see F for femur, T for tibia. Or they might mark femur nail and tibia nail. And then it might give you time for you to remember that the femur has a bow, whereas the tibia has an acute bow just at the proximal part of the nail. Good. All right. Yeah, tell me.
Are those the same lock nails or are they different types of nails?
There are different types of nails. These are the stainless steel old traditional nails. But the nails that you all will see now will be the titanium nails, and they would be locking nails. We don't use non-locking nails anymore because remember, fracture has has different dimensions. When you have to reduce a fracture, you have to reduce the angulation, the displacement, as well as the rotation. So if you place a nail in a bone, you would be able to reduce the angulation, you'll be able to reduce the displacement. But if you do not lock it proximally and distally, then you could not control the rotation. So because of that, all nails now must have holes proximally and distally to lock, to put the locking screws. Yeah?
Are
Yes,
the
Doc.
nails
Yeah.
removed after healing?
Pardon?
Are the nails removed after healing?
No. There's no indication in adults to remove the nails after healing. There are few indications in which you have to remove a nail. One, if it causes infection. So hardware infection, you must remove the nail. Two, if after it's healed in the pediatric population, sometimes you can opt to remove the nail. Three, in the athletic population, and those high intensity athletes, you can opt to remove the nail. Four, if the entire bone is healed and for whatever reason the patient is having pain, you can opt to remove the nail. But remember, out of those four indications, only one really is an absolute indication, which is infection. The other three are relative indications: pediatric population, symptomatic pain, or the athletic population. The problem about removing the nails is that one is a second surgery they have to do. So that in itself is an increased risk of infection. Any surgery we have to go back in is an increased risk of infection. And two, if you remove the nail, the bone will be weak, because to remove the nails, you have to remove the screws. And usually you have two screws above and two screws below. And those screws take a while. The holes that the screws create after the nail is removed takes a while to fill in, months sometimes. So there's a potential weak point in the bone where they could have a fracture. They could have a stress riser and they could have a fracture. So because of that, the important thing is to tell the patients, listen, these titanium nails, no, they don't cause any issues. It doesn't poison your blood. That's the fear for most patients. Second question, when rain falls, do they feel pain? Once they have none of those complaints, I would say 100% of my patients don't opt to remove their nails. Good? Right. Let's try to see how much x-rays we could do. We'll see if we could go till 8 o'clock. Personally, for me, 2 hours is a lot. People begin to get tired. So let's see what we could do in the next 40 minutes. Right. So in terms of x-rays, we love x-rays. For the final exams, we tend to bring trauma. We don't bring much elective stuff in terms of skiffy or hip arthritis or knee arthritis, simply because the orthopedic station is only about what? 5 minutes? Yeah, it's only about 5 minutes for the orthopedic station. So in 5 minutes, we want to focus on the basics. So this is just a basic clavicle fracture. And there is the, hold on. The mechanism of injury is usually a fall on the outstretched hand and the force is transmitted to the clavicle. There's the Allman classification that classifies clavicle fracture based on the location, right? Most of them are group 1 fracture, which is in the middle third, right? Group 2 is in the distal or the lateral part, and group 3 is in the medial part close to the sternoclavicular joint. The ones that you all will get is the group 1, which is in the middle third. So then the questions would follow that. What are the indications for surgery? What are the indications for conservative management? And you would say once the patient is stable and is an isolated clavicle fracture, by and large, the main indications for surgery are if there's more than 2 centimeters overlap, right? There's more than 2 centimeters overlap, which means I'll just put my video on for a short while to show you all what overlap is, so you all will understand. me just see here. Right. So if the clavicle is broken, if this is a clavicle and it's broken in the middle, overlap means that distance between this tip here and this tip, the horizontal distance, if it's more than 2 centimeters. So in other words, the clavicle breaks and the top part, one part rests on top. So it's shortened. If it's shortened, your working arm of your upper limb is not efficient as the other limb. So therefore the patient requires more energy to perform task. And then they get pain, they get loss of function, etc. So more than 2 centimeters overlap, or if both bones are broken and they're not touching, 100% loss of contact. So more than 2 centimeters shortening, which is the horizontal distance between both ends, or 100% loss of cortical contact. Other than that, almost all isolated clavicle fractures can be treated conservatively, right? They can be treated conservatively. How do you treat them? In a sling, a broad arm sling. Clavicle fractures could also occur in newborns with shoulder dystocia, and they almost always heal on their own. Within 2 weeks, you've seen fulminant callus on the x-rays. What you do need to tell the patients, especially if they are young female girls, they will have a bump on their clavicle. It will heal with a bump. Over time, the bump will get smaller because, as we all know, in bone healing, the last phase of bone healing is remodeling, in which you have osteoclastic activity starting to remodel the bump. So it gets smaller. It doesn't go completely, but it gets smaller. Right, next slide. Anyone, diagnosis, quick.
Shoulder dislocation.
Pardon? Tell me?
I said shoulder dislocation.
Okay, shoulder dislocation. Anything again? Anyone? Agree?
Soft tissue
Anterior.
Someone said anterior.
Yeah, anterior shoulder dislocation.
Okay, anterior shoulder dislocation. So the shoulder there is perfectly fine. So when you request an x-rays for the shoulder, it's important that you ask for 2 views, AP and a transscapular view, right? In the AP view, this is a glenoid, and your shoulder should be under your acromion and lateral to the glenoid. On a transscapular view, you have your acromion come down to the V, coracoid. The coracoid is this, which is this here. This is a coracoid. Right? So this is a coracoid, and it goes down to the blade of the scapula, more or less like a Mercedes Benz. So if you're looking at this long blade, remember this is transscapular. So the x-ray is shooting across the thickness of the scapula. So you're looking at your scapula here, going straight up the blade. Acromion, how do you know which one is acromion and coracoid? Because the acromion articulates to the clavicle to form the acromioclavicular joint. So wherever the clavicle goes on to, that's the acromion, and that's posterior. The coracoid is anterior. And the head of the humerus is in the center of that Mercedes-Benz sign. So you all seen the Mercedes-Benz sign? Ladies and gents, are you all seen it or no?
Not really.
Stop.
Pardon?
Yes,
No,
I'll
not
take it.
really.
Oh, someone said no. Okay, let's go over it again. Mercedes-Benz have like the 3 spikes. And so the first spike is this here, which is the acromion coming down to the center. The second spike is from the center going to the coracoid. From the center going to the coracoid. And the third spike is from the center going straight down to the blade of the scapula. So those 3 lines, 1 line, 2 line, and the third line joins to form the center point there, which is the glenoid. And the head of the humerus, which is what I'm outlining here, would be in the center. So the shoulder is perfectly in place. What the patient have is a disruption of the acromioclavicular joint. So you can see the clavicle is a bit superior. This clavicle should be down. So if I were to draw a line on the superior aspect of the acromion and follow it through, that is where the superior border of the clavicle should be. So this patient has as seen in this drawing, if I draw a line on the acromion, it will go straight across. So if we go back now, you can see a draw a line and the clavicle is up in the air. So this patient has an acromioclavicular dislocation. And with acromioclavicular dislocation, the importance there is there's type 1 to type 6. Usually type 1 to type 3 could be treated conservatively in a sling, whereas type 4, 5, and 6 usually require surgical treatment. Right? You all just say open reduction and internal fixation at your level. You don't need to know what surgery it is. And even if you forget the classification, say, doc, once it's minimally displaced or undisplaced, we could treat in a broad arm sling. If there's any degree of displacement, it requires open reduction and internal fixation. And that's all you need to know. Let's not focus too much on that. Let's focus on this now. What is this? Before we go to that, let's focus on this. All right, what are we seeing here? This is a shoulder dislocation. If you look at this, the humeral head is medially and inferior to the glenoid, as opposed in the diagram before, where it is in line with the glenoid. In this case, it's moved medially, so it's moved inward, and inferiorly to the glenoid. If I ask you what type of dislocation this is, all of you all will jump up and say anterior shoulder dislocation. And I would say, well, I can't determine if something is anterior dislocated until you do a transscapular view. I don't have a transscapular view to show the dislocation here, but this is the transscapular view. And in the transscapular view, it's important to know that the acromion is posterior and the coracoid is anterior. It's important to know that the acromion articulates with the clavicle. That is how you can differentiate which one is acromion and which one is coracoid. So therefore, if the humeral head sits in the center like this, it's normal. If the humeral head moves this direction and is here, it's a posterior dislocation because the acromion is posterior. And if the humeral head moves this way, and have an imaginary circle under the coracoid is an anterior dislocation. So just divide this into 3 quadrants. Quadrant 1 in line with the acromion, quadrant 2 in line with the center, and quadrant 3 in line with the coracoid. Humeral head here, anterior dislocation. Here, normal. Here, posterior dislocation. Everyone got that?
Yes, sir. Please.
Okay, so when we face with a shoulder dislocation, you cannot determine if the shoulder is dislocated anteriorly or posteriorly from an AP view. AP view will just show if it's gone medially, inferiorly. You need a transscapular view in addition to AP view. The transscapular view is this view. In the transscapular view, the acromion, which is this here, is posterior. How do we know where the acromion is? It articulates with the clavicle. This clavicle should have been down in a normal shoulder. And the coracoid is anterior. So if the humeral head is here, it's a posterior dislocation with the shaft. If the humeral head is here, it's normal. And if the humeral head is here with the shaft, it's an anterior shoulder dislocation. Right. So when the humeral head dislocates, it rotates. It's usually a fall on the outstretched hand. It is important to understand that there are associated injuries that may occur, both soft tissue as well as bony injuries, that could occur with a shoulder dislocation. So the shoulder dislocates inferiorly and medially in an anterior shoulder dislocation, which is the most common type of dislocations. It can't go superiorly because the acromion is preventing it there. It can't go medially, direct medially, because the glenoid is preventing it there. And it can't go laterally because the deltoid is wrapped around it. So the only free space the humeral head has to move is inferiorly. So therefore, sometimes when it dislocates inferiorly, it chips piece of the glenoid with it. Because remember, when you fall, the shoulder, the muscles contract and the humeral head is pulled forcefully, inferiorly and medially, as shown in this diagram. So on its way from here to here in the oblique direction, it could chip piece of the inferior aspect of the glenoid, as seen here. And this is called a Bankart lesion. For those of you all, this is called a Bankart lesion. A Bankart lesion is either a bony Bankart lesion of the glenoid, or it could be a labral Bankart lesion of the glenoid. As we all know, the shoulder is a very shallow joint. The glenoid is very shallow. So the glenoid is rimmed around circumferentially by a fibrocartilaginous tissue called the labrum. So if any one of y'all would ever see a cadaveric dissection of the glenoid, you would see a ring circumferentially around the glenoid, which is called the glenoid labrum. And on the way down during a dislocation, that labrum could be torn. That is called a labral Bankart lesion. And sometimes the bony part of the glenoid could become chipped. That's called a bony labral lesion. So even when you reduce the shoulder and it comes in back nicely here, because the inferior stabilizers of the shoulder have been damaged, this patient is predisposed to recurrent shoulder dislocation. I'll just put in the video again quite quickly to show you all something again. And sometimes, let's say this is the glenoid, for those of you all who still online, and this is the humerus. This is the glenoid here, and this is the humerus. When the humerus dislocates and it hits the inferior part of the glenoid here, that is what will cause the labrum. But remember, the humeral head as well also impacts when it rotates. So the humeral head itself could become chipped. That is called a Hill-Sachs lesion. Right? That's called a Hill-Sachs lesion, as seen on this diagram here. You can see the humeral head is nice and spherical here, and then it stops here, and you can see it's rough. You're not seeing a humeral head here. So part of the humeral head is chipped. Why? Because it impacts the glenoid rim. This is a glenoid here. This is an auxiliary view, by the way, but you all would not get this in exams, right? The Americans actually use this as a standard view in the shoulder dislocations. So you can see from this view that while the humeral head is dislocating, it impacts on the glenoid and part of the head could chip. That is called a Hill-Sachs lesion. Other structures that could be damaged during the dislocation would occur the rotator cuff muscles, could also become torn. The ligaments could become torn, the glenohumeral ligaments could become torn. So the humeral head could be chipped, Hill-Sachs lesion. The glenoid could be chipped, damaged, Bankart lesion. The rotator cuff muscles could be torn, as well as the glenohumeral ligaments could become torn. Any combination of those four, or any one of those four in isolation, could potentially lead to recurrent dislocations. What is recurrent dislocation? It's defined as 3 or more dislocations after reduced them, occurring over a space of time. Doesn't matter. Once a patient presents with recurrent dislocation, you need to investigate them via an MRI scan. So the initial scan you will do when a patient presents for the first time with a shoulder dislocation would be a plain X-ray, AP and transscapular. How would the patient present? We're going a little backwards now. Patient could present with squaring of the humerus. What is squaring of the shoulder? What gives the shoulder the contour? The humerus itself. So in this normal looking shoulder, The deltoid is here, and the humerus, if you look at somebody from the front, the deltoid and the humeral head, or the proximal part of the humerus, gives you that convex shaped shoulder. If the humeral head is dislocated anteriorly and medially, as seen here, then that lateral part of the shoulder will be flattened. So the patient presents to you in accident and emergency holding up their forearm, and they are flattening of the lateral border of the shoulder. Could anyone tell me what nerve normally runs under the axilla here from the brachial plexus?
Axillary nerve.
Good. So if the humeral head dislocates inferiorly and medially, it could tug on the axillary nerve. And if it tugs on the axillary nerve, you could get axillary neuropraxia. That's the fifth complication. The axillary nerve is a mixed nerve. It's motor and sensory. The sensory part is in the regimental barge area on the lateral part of your shoulder. So patients could present with numbness there on your C5 dermatoma. So it's imperative in your evaluation that you document if the patient have sensation when they present to you in the regimental barge area. Because if you try to reduce and you did not document it and the patient has numbness after, you have no defense. They could say it has been iatrogenic and you caused it during your reduction maneuver. You would not be able to assess the motor component of the axillary nerve because the shoulder is out. So you can't assess the deltoids. Right? So on examination, you check the C5 dermatome, you document sensation, you look for flattening of the lateral border of the shoulder, and you also look to see under your coracoid if they have fullness. So I'll just show you all again, I'll just show you all a video. So if I were to look at my shoulder, my coracoid is somewhere here in front, just right here. Right, this is my clavicle going across, and under the clavicle, right here, is my coracoid process. And this is my humeral head. This is where my humeral head is. I have a nice convex border of my shoulder. If my shoulder dislocates medially and inferiorly, the humeral head comes under my coracoid now. So when you palpating under the clavicle, under the coracoid, you'll feel a bump. So you call that infraclavicular or subcoracoid fullness. The three things: loss of sensation on the regimental barge area of the shoulder, that's one. Flattening of the shoulder, the lateral border of the shoulder, and infraclavicular or subcoracoid fullness. Doesn't matter whether it says infraclavicular or subcoracoid, the humeral head is below both. You could use whichever terminology you want. That's examination. Investigations, x-rays, AP, transscapular. Management, reduction. How do you reduce? Under informed consent, conscious sedation, and adequate analgesia, you attempt to reduce. What do we mean by informed consent? It doesn't have to be signed. You just have to explain to the patient what you're going to do. What is adequate analgesia? Opiates. What do you need for reversal of the opiates? Naloxone. What do you need for sedation? Sedatives, the benzodiazepines. What do you use to reverse the benzodiazepines? Anyone?
Flumazenil.
Yeah, flumazenil. Very good. They must have oxygen in hand. Right? Some people use ketamine and so forth. And you must monitor the patient vitals. So you have the different maneuvers. Any one of you all know about any of the maneuvers? The team approach is the one that we tend to use. And all you need to see, team approach, TEAM. T is traction, counter traction. E is external rotation. A is a deduction, D as in dog, not abduction, a deduction. And M is medial rotation. And that's all I need to tell the examiner. And then form consent, consent sedation, adequate analgesia, and we crash cut. I'm now going to do the team maneuver, which is traction, counter traction, external rotation, a deduction, and medial rotation. And let's say you do that several times and it doesn't go in. Your next step would be to consent the patient with general anesthesia. Especially in muscular patients, sometimes, even with the sedation, the muscle's still in spasm. And the minute you put a tube down their throat or LMA airway and they fully relax, it pops in back spontaneously. However, you have to ask yourself, there are things that could occur that will block the reduction, mechanical blocks. And these are usually if they have associated greater tuberosity fracture, which is the sixth complication that could occur with a shoulder dislocation. If they have a humeral head fracture or a lesser tuberosity fracture, or any fracture as a matter of fact. Because if you have a fracture anywhere here, and you tugging and pulling on the shaft, because the fracture prevents connection of the humeral head, then no matter how much you pull, you're not pulling the humeral head, you're pulling the shaft away from the humeral head, if anything at all. So of course it would not go. And sometimes, if the greater tuberosity is fractured, it goes in the joint. So you have to tell the patient that we may have to do open reduction, plus or minus internal fixation, and reduce your shoulder if it does not go in. So there are three scenarios with a shoulder dislocation. A simple dislocation that pops in itself, in which case you put them in a broad arm sling followed by physiotherapy. A simple dislocation in which later on they get recurrent dislocations, in which case you do an MRI and you look at the causes of recurrent dislocation, Bankart lesion, Hill-Sachs lesion, glenohumeral ligament injury, rotator cuff injury, or a complex dislocation that involves a fracture at the point in time in dislocation that prevents reduction, in which case you go in immediately within 24 to 48 hours, and you may have to do open reduction and internal fixation. Always assess axillary nerve before and after the dislocation. You want to stop there? You want to go on? You already have 2 hours. This is quite a lot. There's the general consensus, guys.
Doc, I have a question while you're deciding. And you was talking about the team approach for your treatments. If I see Stimson's alternatively, well, I still.
You could tell me what Stimson's is, of course. I have no problem with that.
Okay.
But try to mention what is in vogue before you mention something out of the ordinary.
Okay.
If you just go straight to Stimson's, we'll be like, well, why are you doing that without doing step 1?
Yeah, true.
Yeah?
Makes sense. Thanks, Doc.
Okay.
Doc, I had another question. I know you mentioned it more than once, but when you were talking about the Bankart lesion, you said that there are 2 types, the bony labral, and what was the second type?
You have the labral Bankart and you have the bony and labral Bankart. So it's either the labrum alone could become torn, or the labrum and the bony attachment could become torn. Remember, the labrum wraps circumferentially around the glenoid. So the Bankart lesion is the inferior aspect of the labrum and or bony labrum that could become torn. This is the labral Bankart versus the bony Bankart. But the bony Bankart could have a piece of labrum attached to it as well.
Thank you, Doc. Okay.
I know you all have exams, but guys, I think it might be a bit too much to push all this tonight because you all probably would forget quite a lot.
Yeah, Doc, I think you covered a lot today, to be honest.
Right.
Which was really helpful.
Right. So we could either probably have our next session and finish up the trauma. It's up to you all because I know you all have exams and having these class kind of deters you from your structure, your study that you have from now to the 12th. So just liaise with me, Varindra. Right? Just liaise with me, get the general consensus, and even if it's an hour and a half, sometimes during the week, just let me know.
Sure. Doc, would it be after the MCQ, right? We actually have about a week in between until the OSCE. Would it be possible to have a session?
Yeah. Just talk to me now and we could sort out something.
Sure, no problem. I'll just get some feedback from now and I'll end.
Okay, great. Take care.
You too. Thanks a lot, Doc.
Bye. Yeah, bye.